tell you about a whole new approach to doing public health. And this is really what, some people have called precision public health, or risk stratified public health. And what we're really doing this is about mothers and newborns at the time of birth. I don't have any conflict of interest. So we know that a lot of the mortality that we talking about postpartum occurs, in the first few weeks after birth. So this is really an extremely vulnerable time, both for the mother and for the baby. And during this period, WHO recommends 3 postnatal visits. But in some work that we've done fairly recently, in Uganda, where we do a lot of our work, it really showed that, only about 50% of mothers even received 1 visit. And this visit was really at the wrong time, so it was certainly not early enough. And it's also important when we look at this, we get this 2 for 1, when we can look at this mother and child as this integrated unit that we call a dyad. You've heard that term today. But it really is that the impact of this, if the mother gets ill or the baby gets ill, they impact each other. So it's really an opportunity to look at this dyad together. And we use this approach using what we call risk-stratified postnatal care. So instead of trying to get everybody to 3 postnatal visits, what we're trying to do is to target the postnatal care at those mothers and babies most at risk and understanding this interaction. To do that, we use a data-driven approach. So what we do is we collect readily available information at the time of delivery from both the mother and the baby. And in this research project, we collected nearly 200 different variables. And then instead of the current approach, which everybody gets the same postnatal care, what we're trying to do is we target the postnatal care at the highest risk. And that's really very economical way of looking at this and very efficient way of doing this. And obviously those that are at lower risk, they get a lower level of care. They get some care, but a lower level of care. So how do we go about this? We need a model. So what we do is we spent an enormous amount of time, and this takes years, and I'm a SLAB graduate, and I've taken much longer than it took in doing very similar work. It takes a long time to actually do this. We had to go and collect data from a huge cohort of mothers and babies at the time of delivery. And then we follow those mothers and babies up very intensely for 6 months after delivery. And we have a look at those mothers and babies' outcomes, and from that we develop models. And today what I'm showing is really the model from the mother that we can look at. These are readily accessible things. Did you have a cesarean section? What was your heart rate? Did you have urinary tract infection? Very simple things that we can measure at the time of discharge, and from that we can pretty accurately predict which of those mothers are going to develop complications. And this complication was the need for readmission. And then using that model now, we build that into our risk-stratified care. And of course, the next phase of this project that we're hoping to get funded now is to take this model and implement it within a clinical environment. Because no use having a model to be able to estimate the risk unless you can take an action based on that. So we've now got to decide what actions are we going to do based on this model. And we do that through a systematic review of the literature, of what's out there, what we should do for these mothers and babies at the same time. But also, we work with our stakeholders to understand what's feasible in the local environment. What can they reasonably afford? What would be practical for us to do? And then we move on to a feasibility trial where we'll implement this model in clinical practice, as we have done in other settings around this risk-stratified care for mothers and children. Thank you very much. Happy to take some questions.
What are the limitations of AI in this case?
How many weeks have you got? No, so that's a very leading question. I think that, that probably is a message. Of course, AI is coming in healthcare whether we want it or not, and I think it has a potential to do enormous good, and particularly in those settings where maybe we don't have the expertise that we actually need. But of course, there's lots of risks around using AI. And just to be clear, this is not generative AI. These models are logistic regression models that you know, are based on data that is publicly available, that is available for anybody who wants to do research on this. You know, these are very robust models, and we spent, the reason why it's taken 15 years for us to get there is we spent a lot of time on the validation of these models. So I presented here, in fact, the second phase of development of these models, but there will be lots of additional phases during the implementation where we'll do additional external validation associated with that. But of course, there is always the risk that you don't identify a mother who's at high risk or babies at high risk. But that happens in clinical practice anyway. And we've shown in most of these settings, the models can do much better even than the expert clinician.
Thanks, Mark. A very realistic study. Are you considering having a cost impact assessment in the next phase?
Yes, William. So in all of our previous studies, and we've done this risk stratified care in settings of children who are discharged from hospital after critical illness. We've done it for triage, and we will do it for this as part of the implementation phase of this project. We always do an economic analysis. And you can appreciate that, you know, these, certainly in our triage application, it's 100% economically effective. And the reason for that is that it significantly reduced the number of admissions for children. So in and of itself, the intervention, yes, it costs some money to set up the infrastructure and the data, but it allows us to really save costs. And I think, as Tor mentioned earlier, that's crucially important when we try and sell it to governments. We really have to have that ability to show that we can improve outcomes, but at the same time save costs. And just to say, these programs we have an algorithm, but the algorithm is really not the treatment. The treatment is the quality improvement that is driven by these type of algorithms.